What will I gain from this video? At the end of the video, you'll be able to identify right upper lobe, right middle lobe, and right lower lobe collapse. The radiological signs of lobar collapse are direct, and that is the shift of the fissures. The indirect signs of collapse include increased lung opacity, compensatory hyperinflation, hilar shift, mediastinal shift, elevated diaphragm, crowding of the ribs, crowding of the pulmonary vessels, or obscured borders of anatomical structures. Keeping these signs in mind, we will now review collapse of the right lobes. Within right upper lobe collapse, on a PA, the minor fissure will shift superiorly and medially. The trachea can be deviated to the right, and the ribs over this area can be closer together than normal. On the lateral chest x-ray, there will be an area that is too white in the upper zone of the right lung. The superior part of the oblique fissure above the hilum shifts anteriorly and superiorly, and the minor fissure shifts superiorly. When we have only partial collapse of the right upper lobe, we can expect increased opacity within the right lung and superior displacement of the minor fissure. When we look at an actual case and what it looks like, we see the displacement of the fissure as well as the parenchymal changes within the right lung. In this case, there's an additional elevation of the right hemidiaphragm. On the lateral x-ray, we would expect to see an opacity within the apical portion of the lung, as well as superior shift of the minor fissure and anterior shift of the oblique fissure. And here we have a representative case with the oblique fissure identified posteriorly that is displaced significantly anteriorly, and the horizontal fissure is displaced in a superior direction. With more advanced collapse of the right upper lobe, the opacity within the right apical region will look more white, and the displacement of the oblique fissure will be more complete. In these more advanced cases, we would expect that the hilum would be elevated and that there would be compensatory hyperinflation of the remaining non-collapsed lung. On lateral film, the collapse may be very difficult to identify as the collapsed right upper lobe continues to lose air and becomes hidden within the soft tissues within the superior aspect of the hemithorax. In this illustrated case, we can still see the collapse, but that is partly because the collapse was caused by a mass which was located within the inferior aspect of this opacity. Here we see another example of right upper lobe collapse. In this case, we see that the edge of the collapsed lung is irregular. It's lobulated, that there is a protrusion of opacity here more inferiorly. This is called the golden S sign, and this occurs when there is a central mass causing obstruction, and the obstructed lung is trying to pull the fissure upwards, but the fissure is being held down by the mass within the hilar region. And this results in this reversed S shape of the edge of the collapse in combination with the edge of the mass. Here is another example of a right upper lobe collapse due to a central mass. Here we see the oblique fissure being displaced forward, and this bulge is part of the mass on the AP view. The lateral view shows the edge of the collapsed right upper lobe and displacement of the fissure anteriorly. Sometimes also we can see an unusual appearance of the diaphragm with upper lobe collapse. This is called a tenting sign and is due to pulling of the diaphragm superiorly due to the volume loss within the upper lobe. And this can be seen with right upper lobe collapse as well as with left upper lobe collapse. In right middle lobe collapse, the direction of the collapse on a PA film is medial and inferior, and the minor fissure will be displaced in this direction. On the lateral film, we would expect the minor fissure to be displaced inferiorly and the inferior aspect of the oblique fissure to be displaced superiorly. In this example, on the right, we can see a subtle difference in opacity of the right lung as compared to the lingula within the left lung. But if we look on the lateral x-ray, we can see a definite triangular opacity overlying the heart. This is almost complete collapse of the right middle lobe. With right lower lobe collapse, the collapsed lung will collapse in an inferior and posterior direction. The minor fissure will be shifted inferiorly and posteriorly. On the lateral X-ray, we will see the oblique fissure displaced in a posterior inferior direction. With the collapse, we will see an opacity within the right lower hemithorax with a straight edge superiorly. This forms almost like a triangular shaped density behind the heart on the right, with preservation of almost the entire right heart border. On the lateral view, we can see an opacity within the inferior aspect of the left hemithorax, but we have difficulty in identifying this collapse on the lateral because of the degree of collapse. So in summary, collapse within the right lung can involve the right upper lobe, the right middle lobe, or the right lower lobe, or a combination of lobes. Look for displacement of the fissures. The lateral is very important, as we outlined with right middle lobe collapse, which was almost completely invisible on the PA view.